Thank you very much. I need to thank the committee for inviting me along to speak. I've never been to the Netherlands before, so it's been an experience. Yes, I'm from Rotherham, not Rotterdam, which is a relief for those people who are from Amsterdam. It was funny. I went out for a walk. It's incredibly flat. I live in a city called Sheffield, and everything is like this. It's up or down, up or down. So to see so many people cycling without gears and lycra on is really unusual for us. So it's a lovely place. I'm going to be talking today a little bit how we come up with a diagnosis in the resuscitation room. How do we do that? So I'm going to start with a case. No resuscitation without Lego people seems to be the way we're going things, isn't it? Okay, so you get a phone call from the ambulance service saying that they're going to be bringing in a 27-year-old male who's collapsed at a restaurant, apparently, and he's been fitting for about 20 minutes. What do you think's wrong? What diagnoses are going through your mind at the moment? They say they're going to be 5 minutes. And sure enough, 5 minutes later, they appear in the resuscitation room. Only there's been a mistake. It's not a male patient, it's a female patient. There was a miscommunication. And the reason that you know it's a female patient is that she's clearly heavily pregnant. Somehow that didn't get through. She's in the later stage of pregnancy, probably going to give birth in the next couple of weeks. You're hoping not the next couple of minutes. Does that change what you're thinking now? Now I'm on. Does that change what you're thinking in terms of your diagnoses? Now, 5 minutes after that, the husband appears. He seems a little unusual, it has to be said. He doesn't seem terribly distressed about what's going on, but he gives you some information. He tells you that his wife has a nut allergy, but she's never used the EpiPen she was given when she was a teenager. She's been feeling a little bit unwell recently, a little bit tired, a little bit of a headache, but they've put it down to the fall that she had when she was in the bath 2 weeks ago. Has that changed what you're thinking? Has that altered what your diagnosis might be? Now, clearly this is a little unusual, this case. I've created it in such a way that there's lots of changing information. But those of us who work in critical care know that that's exactly what happens, isn't it? Information gets passed through, there's limited information, it's often a little bit subchangeable, and sometimes it turns out to be actually completely wrong. That's what we do. And yet, isn't it incredible that we still manage to do our job? Isn't it incredible that we still managed to come up with a diagnosis, let alone a management plan for what to do next? I wonder, have you ever thought about that? Have you ever thought about how incredible it is that we can do this? How improbable a skill it is? Have you ever thought about how you think in resuscitation? And that's what I'm going to spend a little bit of time talking about, and then thinking about how we can get better at it. Okay. The easiest thing to start with, though, is to think about what we're not doing. Okay? When we were brought up as medical students and junior doctors, we were taught very much how to come up with a diagnosis. You all remember, you take a history, a full history, okay? You then do an examination, a full examination, okay? And then after that, you come up with some differential diagnoses, and then you order some tests, and then you wait for some test results to come back, and then you sort of perhaps ask for some more information, and then perhaps do some more tests, and eventually, you hone down to what you think the diagnosis is. It's, if you like, an analytical process, okay? We weigh up the information, we consider everything, we work our way through. Now, the temptation would be to believe that that's what we're doing when we're in the resuscitation room. It's just we do it really, 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 really quickly. But if you stop and think about it, that's not actually the case. You see, for an analytical thought processes, what we need accurate information. Okay? The information can't be changing all the time. You need accurate information. You often need very specific pieces of information to get what you need. And it also takes time to process. And that doesn't really fit with what we see in resuscitation. In resuscitation, as I demonstrated at the start, information is often uncertain or missing. It's dynamic, and the variables are constantly changing. And we need to make rapid decisions. Analytical thinking, by the time you get the answer in resuscitation, everything's changed. Analytical thinking just won't work terribly well in the resuscitation room. If you like, from Tom's talk yesterday, it's what is it, space station thinking in a mayonnaise world. It's just not going to perform terribly well. So, what's our alternative then? Because clearly we're doing something right, or else all our patients would be dying. So, I'm going to try and demonstrate that with a little experiment. Let me see, I'll come across here, wherever, you could all see me over here, but I'll come to the center. What do you think the volume of this piece of pipe is? Okay, so a piece of pipe to scale, okay? All right, so you can see that's what it looks like, that's the length of it. Just have a think. How much water do you think this bit of pipe would hold if I covered the bottom of it? Yes, I know it wouldn't hold anything if I didn't cover the bottom of it. But if I covered the bottom of it, how much would it hold? Anybody just have a think to yourself. Turn to your neighbor and tell them, how much do you think? Come on, commit to a number. Commit to something. Commit. That's more than enough time. We're in resus. More than enough time. Okay. Now, there is an analytical way of solving this problem. Yeah? Those of you who can remember back and aren't getting sort of shakes about thinking about high school mathematics, the volume of a cylinder, isn't it? So pi r squared h or L, whatever way you want to look at it. That would be the analytical way of solving this problem. But the problem is you don't have the radius and you don't have the length or the height of the pipe. So you couldn't do that. So you came up with another way of doing it. You did come up with an answer. The question is, how? Now, I think what probably happened was, or what I would do, is most people look at the pipe and go, okay, well, it's bigger than a 50 ml syringe, yeah? But it's smaller than a 2-litre carton of milk. It's smaller than a litre carton of milk. I'm thinking, I don't drink alcohol. I'm a great disappointment to everybody who knows me. So I think, well, a can of Coke beside that is probably about half the size, but it's a bit wider. But will that make up for it? Imagine it being a glass and pouring with a bottom on it. If I poured the can of Coke in, would it fill up, their foam in it? I don't think it would quite take a can of Coke. I think it'd be a little bit short of that. I reckon I would probably go for about 300 mils is what I would go with. Were people coming in and around that sort of number? Yeah, around about that. I'd come up about 300 mils, okay? Now, the actual answer, because I measured it with a bottom on it, was 295 mils. So pretty cool. I think that's... Did anybody get 295? I'm just fascinated. Does anybody get it? But listen, how did we do that? How did we manage to get such a reasonable answer when we didn't have the radius, we didn't have that length? Well, what we did was, we did something called analogical thinking, okay? What we did was, we look at our previous experiences. You've all seen objects. You've all judged the size of them from distance. You've compared them to other things. You've seen objects that you know the volume of. So for me, it was a can of Coke. For you, it might be a bottle of beer. I don't know what it is, or what sort of volume they sell cannabis in around here. I don't know how that comes. But you'll have something. And then you'll look at it and go, yeah, but it doesn't quite fit. It's a little bit taller. It's a little bit wider. It's a little bit narrower, whatever it comes to. And this sort of adjusting for variation from our past experiences and then coming up with an answer is called an analogical process, analogical reasoning. And it turns out that we're incredibly well wired in our brains to do this. This is actually how we get around most of the day. So yesterday morning, when I got up and got my breakfast at the hotel, a very nice hotel and a lovely hotel breakfast, when I walked down, I'd never been there before, but when the person said, oh, you want some breakfast, you come through, yeah, that's fine, I'm okay. Because most hotels, roughly the same. There's some muesli and stuff over here, which you just walk past. There's some fruit juice, I like a bit of fruit juice. Somebody's going to offer me some coffee at some point. There's a cooked breakfast over here, over that way. But there's some oddness for me, because I look at, well, they're not always in the same place, so I'm adjusting for that. And then, because I'm on the continent, okay, because I'm in a foreign land, you've got fish and chips for breakfast. And what the hell is that? There's fish, and there's potato wedges, and then there's cheese and meat and stuff. I go, what is this about? So, but I adjust to this, and I adjusted. This morning, it was even easier, because I could remember what stuff was. When you arrived and decided yesterday who you were going to sit next in the lecture theatre, if you'd not met anyone before, you looked around at people and you went, okay, how am I judging who I'm going to sit next to? You were judging it based on previous good and not so good experiences about who was boring, who smelt a little bit, who was a bit odd. Okay, yes, wearing this, I realise. So, who was a bit odd? We're really good. This is what we do. We judge our present situation based on our previous experiences and then adjusting them for what's going on and what we think the likely answer is. That's how our brains work best. And it turns out that's what we're doing in resus. When we see a new patient coming in, what we do is we take all our experience, all our past experiences with us, and we start recognizing bits from past experiences. Patients who looked a little bit like this. Okay, who were the same sort of age, the same sort of demographic. We look at the similar sort of presentations in the history, or what we find on the examination, the observations, the way they're behaving, the way they're responding to previous treatments or not. Okay, this is what we do. And we come up with a best guess for our patient. And not only that, just as you did when I was giving you different information and you were constantly just altering and changing and moving around, you do the same thing in resus. You're constantly reassessing your best guess and thinking, okay, is it still that? That doesn't seem to make fit, and moving around. It's an incredibly flexible way of thinking, an incredibly powerful way of thinking. It's the thinking of experience. It's the thinking of experts, okay? Analogical reason, analogical thinking is what we do as experts in the resuscitation room. And we need to embrace that as what we do. Don't be scared of it. Understand that's what we do. We are not analytical thinkers in those first 10, 15, 20, 30 minutes in the resus room. We gradually move away from the analogical, a little bit more into the analytical stuff when we've got time. But in those first opening stages of resuscitation, a lot of what we're doing is analogical. Okay? That's why when you take someone off the ward and drop them, take the ologist, okay, and they come down to help into resus, and they just go, oh, like that. Because things are happening too quickly for them. They don't think like that, bless them, okay? But the way they think works for where they are. That's brilliant, okay? But in resus, it's not working, okay? So that's how we think. And if that's how we think, then I think we have a duty to our patients to understand how we're thinking and to work at getting better at it. Okay? We need to get better at it, and we need to train our trainees to understand that's what they do and how to get better at it. And that's what I'm going to spend the next little bit doing, thinking about how we can get better at analogical thinking. So, here we go. 3 ways that we can get better at analogical thinking. The first one is feedback. Feedback is absolutely vital. We need to know what the final diagnosis was, okay? Now, the problem we have when we work in resus is, yes, sometimes we will get a definitive diagnosis there. Maybe somebody comes along with their ultrasound and gives us the answer, okay? Or a CT scan or a blood test or an ECG, something gives us an answer. But not uncommonly, and I would suggest probably more often, the patient will leave the resuscitation room with a presumptive diagnosis. And the final diagnosis may be hours, sometimes days, and occasionally weeks away. Sometimes it comes from the pathologist. We need to make sure that we have a good method of getting those final diagnoses back to us. Because if we don't get them back, then essentially our experience is meaningless. If we don't know what the outcome was, the experience that we've just had is of no use to us from an analogical perspective. Okay? I had a patient that I saw with one of the juniors a couple of days ago, and the story was increasing shortness of breath over a couple of weeks, bit of swelling in the ankles. It was a fairly non-specific sort of gentleman. He looked like probably maybe a little bit, we'd come up maybe a bit of heart failure, maybe there's a lot of flu around in Rotherham at the moment, maybe that was going on, maybe a PE, possibly. It was a little bit odd, his both legs were swelling. So we had this sort of triumvirate of diagnosis, but I was fairly confident it was probably more likely going to be heart failure, maybe a little bit of infection that was causing it. But we were in there to exclude a PE as well. His D-dimer came back at 10, which was a little bit sporting, came back high. And it turned out he had a CTPA done by the inpatient team because he was moving through. Otherwise, I wouldn't have seen the result. But somebody actually let me know what the result was. And it turned out that he did have a pulmonary embolus in his right upper lobe. He also had a pulmonary embolus in his right middle lobe. He had one in his right lower lobe as well, as it turned out. And one in his left upper lobe. And yes, you've guessed it, one in the left lower lobe as well. He basically had been showering off pulmonary emboli. Now, that's really important for me to know that. For all I knew, I'd done okay. As it turned out, the diagnosis I thought was least likely turned out to be the right one. That doesn't mean I was wrong, okay, in terms of what I was thinking. But that feedback matters, and I've spent the last number of days thinking about, well, why did I get that diagnosis incorrect? What was I thinking? What conclusions did I jump to? And it's been interesting to think it through. Feedback is important. Feedback is vital. Without feedback, our experience is meaningless. Here's something else I think we should be doing. I think rather than just writing down the diagnosis, we should be writing down our thinking behind the diagnosis. Now, I'm not asking for a full paragraph, okay? I'm asking for just some ideas about, so because of this, this, and this is what I think's wrong, okay? And the reason I think that is because often our feedback is delayed getting back, okay? And so by the time we get the feedback, we've forgotten what we were thinking, how we were thinking at the time, okay? So that becomes a problem. But I think there's 3 other good reasons for writing it down. Let me take you back to school days and school mathematics. I apologize for that for anyone who's suffering trauma with that. When I used to write down mathematics questions, I used to just put the answer down. I'd do this some in my head and write the answers down. My teacher kept saying to me, no, you've got to show your workings. Show how you got the answer. And there were 3 really important reasons for that. 1, if I got the question wrong, she could give me some credit for what I was trying to achieve if I was doing something right. Secondly, when we went back over the questions, when I got one wrong, we could sit and we could work out why I'd got it wrong. Was it that I'd made a simple calculation error? Was it that I was trying to do the right thing, but I'd got the formula wrong? Or was it that I got the right formula, but I was using it in the wrong place? It helped us understand what was going on so I could be educated. And finally, the act of writing things down made me more likely to get the question right, because I was less likely to make silly mistakes. We could write things down. I was less likely to make a mistake than trying to do it in my head. And I think we'd be fools not to take advantage of those 3 advantages when it comes to our clinical work. When we make mistakes, and we are all going to make mistakes, we learned that yesterday. When somebody goes back over the case and looks at it in retrospect, if they can see what we were thinking, not just the outcome of our thinking, they can start to understand the difficulties we faced, what we were thinking, oh, right, okay, now I understand why they're doing that. And then hopefully what we get from an investigation is something useful. Rather than you were wrong, be better, we can go, okay, so we understand why that went wrong. Perhaps you need to rethink what you're doing here, but perhaps we need to do something about the system that created that way of thinking. We'll get something more useful out of investigations. I think it's useful for us as individuals, if we're reviewing our cases, to spend time thinking about what we were thinking about. And with our junior colleagues, talking to them, okay, what you got as the answer isn't as important as how you got there. You may have been right, but your thinking processes were all over the shop, okay? Or you may have been wrong, but you know what? That was really good up until this bit, okay? And we can educate ourselves and others and get better at how we think. The answer isn't as important as the way you get there. And finally, it's one of the few things that's been shown to make a difference to improving diagnostic results. Spending some time actually writing down what you are thinking, that act of restructuring your thoughts, is more likely to make your diagnosis correct. Getting people to slow down doesn't seem to work. Telling them about their biases doesn't seem to work. But getting to think a little bit more in terms of restructure the information you've got so that you come up with the answer seems to help. So we should record our thinking so that other people can understand what we were thinking, so we can educate ourselves and others better, and so possibly we get our diagnoses more often correct. And what's the third action I think we should take? Practice. Deliberate practice. Analogical thinking is a skill just like any other. And as such, it will benefit from practice. Deliberate practice. How can we deliberately practice analogical thinking? Well, if you're anything like me, you work in a hospital, okay? Or you work on the road and you come across patients every day. You can practice analogical thinking on them. In my department, there's somewhere between 250 to 300 patients coming through the doors. I can practice analogical reasoning on them. I can listen to what the triage, or just read the triage notes, or what the triage nurse has said, and just for a second, just think, well, what I think's wrong? Right. Or read the ambulance crew's notes and decide what's wrong. Or listen to the junior as they present just the beginning of the case and say, right, just stop there, let me think. I think this might be, and commit to a diagnosis. Practice doing that. Now, as we said, feedback's important, so it's really important that we go through the process of finding out what the diagnosis was at the end, but you can do that. You can practice every day with real patients. It's dead easy. The other thing that we can do is we can practice with colleagues' patients. It means talking to each other about different cases isn't just gossiping. Isn't that nice? Okay? It's important. Now, going and talking to each other about each other's rare diagnoses, not quite so good, but talking about stuff, talk about the diagnosis, but then ask your colleague, why did you think that? Because that's not what I'm thinking. I would have thought this. I would never have thought of that. I wonder why. Now, it may be that they've got different training to you, or they've had different experiences with different patients, or it could be they've been to a conference or read something in a journal that's different that you've not come across. Or it could be a personal experience of disease and illness in friends or family, or even personal experience. Each of our thinking processes is individual. And learning from other people, listening to what other people think and how they think is really, really useful at getting better at thinking. And finally, we can practice with simulated patients. Now, we could go off to the simulation lab, or we could do in situ simulation. That's awesome. And at the end of it, have a little bit of a think about why we came up with a diagnosis, not just what the diagnosis was. Why were we thinking that? But actually, I've got a fairly low-tech way of doing this. This afternoon, I'm running a workshop using something I call the random patient generator, where we randomly generate patients. And then we get colleagues in the room to come up with differential diagnoses, and then we talk about why that's happened. What is it that's made them think about that? And then we start changing things. And it gives people an insight into the fact that, oh, you think that? Doesn't everybody think like me? Oh, they don't. And you start to learn how other people think, and it challenges your own thought processes. And we'll also give some tips as how you can take that process and bring it to the shop floor and use it to teach juniors. I'd love to see you there if you want to come and explore that a little bit more. Okay, analogical thinking. 3 ways we can get better at it: feedback, recording our thinking, and deliberate practice. So what does this mean for our patient who arrived in resus about 20 minutes ago? What is wrong with our patient? Well, it could be eclampsia, pregnant. Could be an intracranial hemorrhage that's causing the fitting from that bang on the head. Or maybe that strange, unconcerned husband's poisoned her. I don't know. Seems the type. But I'll tell you this. Whatever's going on, the best chance for that patient and her child to survive is that the person who sees her in resuscitation, the clinician, has embraced the concept of analogical thinking, analogical diagnostic reasoning. Someone who has got into the habit of ensuring they get good feedback. Someone who's got into the habit of writing down why they come up with a diagnosis, not just a diagnosis. And someone who's got into the good habit of practicing, deliberately practicing their analogical reasoning. Someone, who's an expert clinical thinker. Thank you very much for your time.